I am Harry Erba, Professor of Medicine and Director of the Leukemia Program in the Division of Hematologic Malignancies and Cellular Therapy at Duke University in Durham, North Carolina. In this presentation, we will review the biology of secondary and therapy-related acute myeloid leukemia. As you know, there are a number of traditional and newer prognostic factors that we recognize in our patients with acute myeloid leukemia. Patient age, performance status, and comorbid conditions are all important determinants of a patient's ability to tolerate intensive therapy, often given with curative intent. However, the biology of the leukemia is also very important in determining the outcome. We focus on white blood cell count at presentation, cytogenetic analysis, and molecular abnormalities to help determine prognosis in AML. However, we have recognized for many years that patients who develop acute myeloid leukemia following an antecedent hematologic disorder such as myelodysplastic syndrome or a myeloproliferative neoplasm, and those who develop the disease following prior cytotoxic chemotherapy appear to have a worse outcome. In this presentation, we will focus on these two determinants of prognosis in our patients with AML. An exciting area of research is the use of PCR next-generation sequence analysis and flow cytometry to evaluate for measurable or minimal residual disease at the time of initial remission following cytotoxic chemotherapy. The incidence of secondary AML increases with advancing age, as can be seen from this data from a Swedish registry. I will now focus our discussion on the results from a Danish registry published in 2015. Between 2000 and 2013, 3,055 AML patients were reported to the registry. The majority had de novo AML, 19.8% had secondary AML, either following myelodysplastic syndrome or another hematologic malignancy, and 6.6% had therapy-related AML. Of the 3,000 patients, 1,567 received intensive therapy. Patients with secondary AML were less likely to receive intensive therapy than those with therapy-related AML or apparently de novo AML. Slightly over half of the patients with therapy-related AML had a prior solid tumor treated with chemotherapy and/or radiation. The majority of these patients had had breast cancer. Almost one-third of patients had lymphoproliferative disorders, and the remainder had multiple myeloma, acute lymphoblastic leukemia, or even non-malignant rheumatic diseases treated with leukemogenic agents. Over half of the patients in this registry with secondary AML had a history of myelodysplastic syndrome, with the remainder of patients having either MDS/MPN, chronic myelomonocytic leukemia, or other myeloproliferative neoplasms. We'll now focus our attention on those patients who received intensive chemotherapy. The 90-day and 1-year survival for patients receiving intensive therapy was superior to those who received no therapy at all. In the intensively treated patients with de novo AML, the 90-day mortality was 15%, compared with 17% in patients with secondary AML following MDS, 24% in secondary AML patients following a non-MDS hematologic malignancy, and 21% in therapy-related AML. At 3 years, patients with secondary AML and therapy-related AML had lower survival than patients with de novo AML, with the highest risk of death, 89%, found in patients with non-MDS secondary AML. The poor outcome following intensive chemotherapy in patients with secondary AML and therapy-related AML was observed regardless of patient age. However, as can be seen here, the effect of secondary AML and therapy-related AML is less apparent in the older patients. Patients with intermediate and adverse risk karyotypes also had worse outcomes compared to patients with de novo AML if they had secondary or therapy-related AML. Again, the effect being less apparent in patients with adverse karyotypes. The risk of developing therapy-related AML will vary due to the different treatment regimens that are used, but also the survival of patients from their primary neoplasm. The risk for AML is 4.7-fold higher after chemotherapy, radiotherapy, or the combination. In this SEER registry database, 7% of newly diagnosed AML patients had therapy-related AML. Let's now focus on the different routes to leukemogenesis in patients with therapy-related AML. Patients who have received topoisomerase II inhibitors such as the epipodophyllitoxin etoposide or anthracyclines or anthraquinones typically develop acute myeloid leukemia with a shorter latency and without a prior history of myelodysplastic syndrome. The AML is often of a monoblastic subtype with rearrangements of the MLL gene on chromosome 11, band 23 on the long arm. However, it should be remembered that other chromosomal translocations that are typically associated with a better prognosis, such as the core binding factor translocations 821 and inversion 16, and even acute promyelocytic leukemia, have all been described as therapy-related AMLs in patients who have received topoisomerase II inhibitors. On the other hand, patients who have been exposed to alkylating agents or radiation therapy, especially radiation that has involved a large portion of hematopoietic bone marrow, often have a much longer latency and a smoldering course with myelodysplastic syndrome. In these patients, cytogenetic analysis often shows complex karyotypic changes, monosomal karyotypes, as well as aberrations of chromosomes 5 and 7. There are different models by which patients may develop leukemia. This may be due to the induction of a fusion oncogene, as can be seen with the topoisomerase II inhibitors. It could be from the selection of a pre-existing cell clone, for example, in patients with clonal hematopoiesis of indeterminate prognosis. Following alkylating agent and radiation treatment, there's DNA damage, and the response to this DNA damage may lead to p53 mutation and genomic instability, or in the setting of normal p53, block in apoptosis and proliferation. Patients with therapy-related acute myeloid leukemia have a worse prognosis than patients with de novo AML, even if they've had a favorable risk karyotype such as the 821 or inversion 16. The same is true for patients with intermediate risk karyotype,